Hi, everyone. Thank you so much for that lovely introduction. I'm so happy to be here. So this is an overview of my talk today. And I'm going to talk a little bit about sleep and survivorship and what we know. And I'm going to talk about sleep architecture in terms of circadian rhythms and sleep needs for adults. Then we're going to move on to strategies to promote sleep and techniques for managing insomnia. And I'm going to show you a couple of resources that I think might be helpful that I hope to share with you, and then take some questions at the end. Next slide. So sleep problems are incredibly common in cancer survivors. Up to 70% of cancer survivors report insomnia. And the cancer diagnosis itself and subsequent treatment has been known to exacerbate pre-existing sleep problems, or they occur as the result of the diagnosis and treatment. Without treatment, insomnia often becomes chronic, and it's associated with a range of physical and psychosocial consequences. Next slide. So the burden of chronic sleep loss is significant. It impairs cognitive and behavioral consequences. There are influences on mood. There's an increased obesity risk with chronic sleep loss. And there's a risk for drowsy driving accidents. And I'm going to go through each of these. Next slide. So the cognitive and behavioral consequences, chronic sleep loss over time can result in poor judgment, lack of motivation, inattention, and we know that sleep loss impairs decision-making ability. Also importantly, and something psychologists care about a lot, is the correlation between sleep deprivation and depression. So anyone who's had a couple nights of bad sleep knows that you don't feel particularly happy, and that really impacts our mood. On a positive note, the improvements can be bidirectional. So if we get more sleep, our mood tends to improve. And there's also correlations between sleep loss and suicidal thoughts and suicidal behaviors. Next slide. Sleep loss impacts, as I mentioned, obesity risk. So there's a large body of evidence linking short sleep to obesity. And part of this is because sleep loss impacts metabolism, it impacts our inflammatory response, and it's an important modulator of neuroendocrine function. So sleep loss has been shown to decrease insulin sensitivity, increase those cortisol stress levels, and increase moderators of hunger and appetite. Next slide. And importantly, there's a burden in terms of drowsy driving. So the National Sleep Foundation don't have exact numbers, but they estimate that about 60% of adult drivers drive, and they say that they're drowsy. And anyone with insufficient sleep is at risk, but there are a couple things that would increase that risk. So if you're driving long distances, if it's dark, and if you're driving alone. A lot of people have the sense that there are these countermeasures, maybe fresh air, caffeine, that's going to improve alertness, but we know that it's not going to. And the reason is because of this concept of microsleeps. So if you're really sleep deprived over a long period of time, your sleep drive is going to temporarily override that voluntary control of wakefulness. So you might not even know that the sleep drive has been taken over. So the key points here are if you really feel sleep deprived, not driving, and that we know that those countermeasures are ineffective, and the drowsy crashes are more likely to be fatal. Next slide. Okay, so I want to switch a little bit into talking about sleep architecture before we get into the techniques. So for adults, our circadian rhythms are based on a 24 to 25 hour cycle, and they're really driven by light. So as you can see here at 7:30, if you get that input from light, daylight or sunlight, melatonin is going to start to stop being produced. We're going to be the most alert at around 10 a.m., the best coordinated at 2:30, and our cardiovascular strength is going to be best at around 5. So for those people who are exercising around 5 o'clock, they're taking advantage of that. And then around 9 o'clock for most people, melatonin, so that's the hormone that regulates sleep, is going to start to turn on. And it takes a couple hours for that to give us sleepy cues. So this is really important when we're thinking about some of the techniques. So I have a lot of adults in my practice who are very sleep deprived and they want to go to bed prior to 9. And that's going to be really difficult because of this circadian rhythm. Likewise, if we're not getting good daylight exposure until noon, let's say you've fallen asleep at 4 the previous night and you're getting up around noon, the whole circadian rhythm is going to be shifted for that day. Next slide. So sleep falls into these 2 phases. There's non-REM stage sleep, and then there's REM stage sleep. So in the non-REM sleep, that's stage 1, 2, 3, and 4. Stage 1, it's really light sleep, maybe 2 to 3 minutes, and you can easily wake up during that time. Stage 2, maybe 10 to 15 minutes, also fairly light stage, and you're going to easily be able to wake up. Stage 3 and 4 is that wonderful deep sleep that's the most restorative. If you're awakened during stage 3 or 4, it's that experience where you feel almost paralyzed. It's really difficult to know what's going on. And then after those stages, we move into the REM stage, which is the dreaming stage. Our breathing becomes more rapid and irregular and somewhat shallow. Next slide. So this graph here just shows you how these stages typically go. So for most people, they go stage 1, 2, 3, and 4 in a predictable way. And the REM stages are very small in the beginning of the night. So that's what you see here. And then as we move throughout the night over the course of 8 hours sleep, our REM stage sleep increases in duration. So that's that experience that you've had. If you wake up in the morning and you feel like you've been dreaming, it's because you've woken up right after a REM cycle. Next slide. So this particular image I really like. So this is put out by the National Sleep Foundation, and it gives a recommended amount of sleep per developmental age. So if we're looking at the adult and older adult ranges here, the recommended amount of sleep is 7 to 9 or 7 to 8, but it also might be appropriate to get 6 to 10 or 5 to 9. I think the takeaway from this here is that there's not a target that you have to attain for sleep. There's a lot of individual differences in terms of how much sleep people need. So this helps us move away from saying to folks, you absolutely need 8 hours sleep versus it may be quite appropriate for you to get 6 hours if you feel really restored after those 6 hours of sleep. Next slide. So what are the symptoms of sleep deprivation? So it's going to be drowsiness, inability to concentrate, impaired memory, certainly moodiness, depression, irritability, reduced physical strength, diminished ability to fight off infection, and then that increased risk for depression. Next slide. And I get asked this question a lot in terms of how do I know if I have sleep deprivation versus insomnia? So if we're thinking about insomnia, according to the DSM, the Diagnostic and Statistical Manual that psychologists and psychiatrists use, we're looking for a complaint about the person not being able to initiate or maintain sleep for at least a month, right? So this is not a one-off night here and there, a couple days in a row where you're having difficulty sleeping. This is a full month where you don't feel like your sleep is restorative. That's one criteria. The second criteria is really about the fact that the sleep disturbance or that you feel so sleepy during the day, it causes you some type of distress or impairment, either in your job, in your social life, or these other important areas of functioning. Next slide. So in terms of treatments for insomnia, medication management, there are certainly many options out there. And these are pretty commonly used. So Ambien, Lunesta, Sonata. These medications, they do help typically in the short term, but they come with risks. So they're associated with psychological associations and dependence. Many patients will talk about feeling daytime grogginess and they feel really sleepy. And the other thing I hear a lot from people is that they feel like at a certain point, the medications plateau. They just don't work as well. So then they're faced with the decision of increasing the dose or having to deal with the insomnia symptoms returning. And then we have cognitive behavioral therapy for insomnia, or CBTI. Next slide. So CBTI was developed by Dr. Jacobs, and we have over 30 years of research on this treatment. It's typically completed in 6 to 12 sessions, and it incorporates these key elements. So, and I'm going to go through these: psychoeducation about sleep, sleep hygiene, some relaxation training, stimulus control, sleep restriction, and cognitive therapy. Next slide. And we know that this is a really effective treatment. I think that's really the point here. So in 75 to 80% of patients, it addresses the insomnia, and it eliminates pill use in 90% of folks. And interestingly, when sleep medications are compared to CBTI, sleep pills increase total sleep time only by about 10 minutes. And again, there's significant side effects that come with those. So CBTI is now preferred as the first line of treatment by the American College of Physicians and the National Institute of Health. Next slide. And importantly, the National Comprehensive Cancer Network encourages all cancer survivors to discuss sleep disruptions with their medical team, as CBTI is also the first line of treatment in efficacy for cancer populations. Next slide. Okay, so let's talk about psychoeducation about sleep, sleep environment, and sleep associations. Next slide. So the key ingredients to healthy sleep, we think about 7 key ingredients. We want the room to be dark. Think blackout dark. It doesn't matter so much this time of year, but as we move into the spring and the summer months, when that light is coming through, we really want to make the room as dark as possible. We want the room to be quiet and comfortable. We want it to be low stimuli, getting all those electronics out of there. We want it to be cool. Consistent, meaning that you're sleeping in the same place as much as you can, and that you feel safe in that environment to the extent that's possible. Next slide. We also want to think about sleep associations. So these are things that we need to fall asleep at the beginning of the night. And all adults wake up 2 to 6 times a night. So all of you who are watching this now, last night you woke up 2 to 6 times a night. And if you didn't know that you woke up, it's because your brain sort of hopped over those wake ups. But if you need television, let's say, or a medication to fall asleep at the beginning of the night, if you wake up, you may need that replicated in the middle of the night as well. So there are these positive sleep associations. Those are things that help us fall asleep on our own. But then there are these negative sleep associations that require something to be present when we wake up in the middle of the night. Next slide. So these are some examples. So positive sleep associations would be white noise, meditation, a blanket that's really comfortable. The negative sleep associations are electronics, scrolling on the phone, television, or hypnotics. So those are the medications. Next slide. Okay, so sleep hygiene. Next slide. So practices that promote sleep, one of the main things that we can do is maintaining an organized and consistent sleep-wake cycle. So that means that we're waking up at the same time on weekends and weekdays. So a lot of people have the sense that if they've had a really bad night's sleep, they can make up that sleep deficit for the previous night. And we really can't do that. So the better approach is to keep a very consistent wake-up time. Keeping a regular schedule of activities, including meals. I hear this often from people who aren't sleeping very well. They might vary when they're having meals, when they're exercising, when they're going out. And then also important in sleep hygiene is increasing light exposure in the morning. And that's to, again, get those cues to the circadian rhythm to suppress melatonin and increase our alertness. Next slide. I also want to talk a little bit about strategic napping. So napping, there's a lot of pros to that. And if it's timed appropriately and it's short, we can get a tremendous amount of benefit from this. So napping in the mid to late afternoon during that circadian trough. So when we are most likely to be able to fall asleep between 1 and 4. And then keeping the nap relatively short. So 30 minutes prevents us from going into that deeper stage sleep. If it's over 30 minutes, that's that feeling when perhaps you've had a long nap and you feel really groggy and almost worse than before the nap. So the short planned naps can really promote an alertness, particularly if they occur between 1 and 4. Next slide. We also want to encourage bedtime routines, so really, really consistent. So here we've got Carlos and Rebecca. They both have bedtime routines, but you can see for Carlos, he's taking a shower, he's putting sleep clothes on, he's reading, and then he's going to bed. And he's doing that in the same order every single night. So it doesn't vary. And that is the idea that it helps our body get conditioned for sleep. So that's what we would want a bedtime routine to look like pretty predictably every night. Next slide. So relaxation training. Okay, next slide. So this is where we just want to think about ways that we can power down. And it's an approach to bedtime if you think about a stop sign. So if you're going 60 miles an hour your whole day, you want to start to pump the brakes long before you get to that stop sign. So this is where we want to eliminate screens, using the blue light filters if needed, and just engaging in quieter activities to quiet our mind. So reading, music, relaxation, all these different things to prepare us for sleep. Next slide. So these are the different applications. Many of these are quite popular. They're apps that you can use to sort of increase that relaxation and anxiety management at the end of the day. Next slide. Okay, so lastly, stimulus control, sleep restriction, and cognitive therapy. Next slide. So stimulus control is the idea that we're going to discontinue any activities in bed that are not conducive to sleep. We're not going to watch TV in bed, use our phone. We're not going to worry in bed. These activities really are cues for wakefulness. So the bed is going to be protected for sleep and sex only. The idea with stimulus control is to only go to bed when sleepy, and you can delay bedtime until you feel sleepy. So there's no set bedtime. If not asleep within 15 or 20 minutes, you get up out of bed and you do something quiet and non-stimulating. When you feel drowsy again, that's when you return to bed and you repeat this cycle. Although it takes a little bit of convincing, this works incredibly, incredibly well. It's hard to get out of a warm, comfortable bed, but if we use that bed and protect that bed for sleep only, our body's going to know what to do in bed. It's going to know to fall asleep in bed. Next slide. So the goal with stimulus control is really just to increase our sleep efficiency. And sleep efficiency is the time that you think you sleep divided by the total time that you spend in bed. And on the next slide, I have some examples of this. So below normal sleep efficiency, this person here got in bed at 11. They took about an hour to fall asleep. They woke up and laid in bed for an hour, and then they laid in bed for another half hour in the morning. So that person was in bed for 8 hours, but only slept 5.5. So they are not very sleep efficient. On the other side, the other person went to bed a lot later, midnight, fell asleep within 15 minutes, and laid in bed for only 15 minutes in the morning. So again, that person only laid in bed 7.25 hours, but they were asleep most of that time. So they're highly sleep efficient. Next slide. And lastly, if none of those things work, we reserve this strategy for the end, which is sleep restriction, not a popular idea, but this also works incredibly well. So if all of those things have not worked, what we would recommend is that you restrict the time in bed to about 4 to 5 hours in order to increase sleep efficiency and consolidate sleep. So once 85% sleep efficiency is achieved, you could then increase the time spent in bed. I did want to say this is not recommended if you have sleep apnea that's untreated. If you have sleep apnea that's treated, it's fine to do this. And I think this is especially helpful to do with a behavioral specialist. Next slide. Cognitive therapy, just very quickly on this, is the last component. Next slide. And this is where we're just trying to identify thoughts that people have about sleep that might be interfering. So some examples would be, if I don't sleep well, I'm not going to be able to function tomorrow. I won't be able to do my job if I get enough sleep, or my health will really suffer if I don't get 8 or 9 hours of sleep. Next slide. And so here are some examples of how we would work on restructuring some of those thoughts. So if I've had a bad night of sleep, this has happened to me before, I can cope with this. So helping somebody reflect on the fact that they've gotten through this before. Tomorrow night might not be my best day. I'm going to feel tired, but I'll be able to do some parts of my job. And reminding folks that 5 hours is core sleep. And so it's important to really listen to my body for sleep cues rather than forcing myself to be in bed for a specific number of hours. Next slide. So just the summary and a take home, things that can really help promote best sleep is setting up your own bedtime routine, not doing activities in bed, using the bed for sleep only, and getting up out of bed if you're not asleep within 20 minutes. Keeping those wake up times consistent, limiting alcohol and increasing exercise, keeping it cool, dark, quiet, and comfortable. And then if all else fails, consulting with a sleep psychologist. Treatment can be done in as short as 6 to 8 sessions. It's designed to be very short term and give people a result. Next slide. So this is the last one. Just wanted to leave folks with some resources. There's a lot out there about sleep. This is the Calm app. I love the Garden of Now. That's a mindfulness-based meditation. If you're looking for a book, Say Goodnight to Insomnia. It's a 6-week program. It's absolutely wonderful book that really goes through in more detail the kinds of things I've talked about today. And then Sleepio is an app that's a 6-week program that you can download and would help walk you through some of these same ideas. Next slide. Thank you. I'm happy to take questions now.